I think perhaps we'll get started. I assume Julian's just about to come in. Okay. All right. Well, we'll get started then. So, welcome to the February's meeting. In terms of welcomes and public questions, we have no public questions, so there's nothing to consider there. And I'll introduce colleagues who are joining us as we get to their item. But welcome everyone. Any declarations or any other apologies, Julie?
No, none received.
Okay, thank you. Declarations of any other business or declarations of interest in the register? Yeah, okay, thank you. Minutes of the meeting of the 14th of December, which is the last public meeting. Any corrections? Yeah. Matters arising 5.2. Any? I think as far as I can see, they're all either actioned or underway, unless anyone wants to raise anything. No? Okay. In which case, we'll get on to the main body of the agenda. Item 6, a board story, Talking Therapies. It's now a great pleasure to welcome James Momer and Randy Griffiths from Talking Therapies. And Debbie, I think you were just going to introduce the item.
Yes, thank you. So Randy and James have come along this morning to give us a patient story showcasing the work they're doing around inclusion and ensuring that there's access for talking therapies to groups that are traditionally harder to reach. So they're going to do about a 10-minute story, and then I know they're going to be keen for people to have questions because they're very passionate and very excited about being here today to share all this. So on that note, I shall hand over. You've got your presentation, okay, haven't you, Randy?
Yeah.
I will hand over then to Randy and James.
Lovely. Thank you so much for inviting us. So I can't see any of your faces while I'm presenting, so apologies for that. But so we're here to talk to you about working with cultural and ethnic diversity in Iact. So Iact is the Improving Access to Psychological Therapy Service in Berkshire, and we're talking therapies. So as you probably will all be aware, there are great ethnic health inequalities in the UK, not just in physical health, but in mental health as well. And those have only been exacerbated by the pandemic and by COVID. So considering that the mental health impact on our diverse ethnic cultural groups has increased, are still underrepresented in psychological therapy services. This has been well known, the gap has been acknowledged, and in 2019 there was a positive practice guide for Iact services for working with BAME communities, and we've been looking at that as part of our new role that started in around kind of September, and looked at the areas within this audit to see how we're doing, what we need to address, what we need to progress in, and what we were achieving and maintaining. And we started that work back in September, and we're kind of moving along in that kind of heading into January and February. So this is kind of where we're at now. So kind of more around more areas that we're kind of really addressing at the moment. But I guess the kind of key thing is how have we achieved this change, and what change have we really been fighting for? So it isn't just a tick box. We have been working across multiple areas to really make the change. And so just an example of it is one of the areas that we worked on is to improve access for non-English speakers. So, but that has included a lot of other work. So it's involved training staff with working with interpreters, therapeutic adaptions. It's been translating our letters, which have historically been just in English, but translating those into key languages, which are Punjabi, Urdu, and Polish. We've been supporting our staff, our workforce who offer therapy in other languages as well. So our multilingual therapists, and providing specialist supervision to really value that workforce as well. We've been liaising more closely with our interpreter service and really addressing issues and developing a feedback form to gather any issues that are happening and be able to kind of really track those much more closely, as well as kind of wider things. So our clinical recording systems called Iactors, and we've gone to them and said, can we have the translated questionnaires that we have on Iactors for us to send out to patients, like we would with our English speaking patients, to send those out in English. So they have, out of all the requests, they have raised the profile of that, and that's something that they're doing as a result of our requests and the work. And it's really key to pull all that in to be able to improve access for non-English speakers, because actually if we're just doing the outreach bit without all this other stuff, we're in danger of putting ourselves in a worse position. We're doing more harm than if we're pulling in these patients and we're not giving them a good service. They're going back to their small communities talking about how the service wasn't great, and then there's a lot more engagement and kind of just work to be done in that case. So it is a much wider thing than just a tick box or a small bit of outreach that we're working on. So driving change is something that we're really passionate about, and that has been kind of, we've thought about it in multiple different areas. So we are much more inclusive now in our social media, in our access, in our profile. We're our tweets and our Facebook posts are the ones that get the most likes from Talking Therapies, actually. And we've published a blog on our website addressing some of the concerns that people might have when they're from more diverse cultural backgrounds. These are just example more of the tweets that we've done. So our work is expansive, and I really don't have time to talk about it all, but they're, you know, what we know is that help seeking doesn't usually happen with NHS services within our diverse ethnic populations. They will more likely go to community organisations, voluntary services, grassroots services, and so we've been working really hard with those services. So James, every week, he's in the Wellbeing Hub, he works with ACRE and men's support groups, really kind of raising understanding and our profile and kind of talking about therapy in a culturally appropriate way. I've been setting up some clinics in refugee and asylum seeking support charities. So we're going out into the community and embedding ourselves in there rather than expecting them to come to us. James has been on the Health on the Move vaccination bus talking to people. We provide training for these organisations to have difficult conversations about mental health with the people that they support and send them kind of our way, as well as contact with kind of faith leaders, interfaith partnerships. You know, there's over 55 different organisations that myself and James are working with. So it's really quite extensive, the work that we're doing, as well as kind of providing therapy and training for adapting therapy and thinking about staff cultural competency, and which has been now not just for our staff, but we've thought about it trust-wide. So the BAME network are changing their name, and that was part of our initial push about not using BAME. It can be quite othering. So that's all about to change now. That's been in process for a while. James is now running for the network, staff network, a Village Voice Talk to Us group every fortnight for staff to come along and be able to have a bit of a safe space to talk. So that's some of the work that we are doing, and James is going to talk specifically about a case and that he's been working with and some of those kind of cultural considerations around that. So over to you, James.
Thank you, Rani, for that. The next couple of slides really are about the patient journey through an appropriate cultural intervention. This lady came to us via a GP into the local Iact, or Talking Therapies, for support with her depression and also anxiety. This lady is from Kenya, which is in East Africa, and did endure a prolonged gender-based abuse or domestic violence. And she left school at a very early age due to the sexual assault, and got pregnant, and then got married to this very hot man that assaulted her. She did make a lot of report about it to the authorities and even her own family, and nobody really listened to her. In fact, she was to be blamed for the whole abuse itself. So you can see how, as a victim, she was also seen as a perpetrator. In fact, from a societal perspective, she was seen as somebody who is bringing shame to the society, bringing shame to the family, because she wasn't really doing what she could do as a wife. And that's the reason why the abuse was coming her way, because she wasn't really doing her job. And she came to this country in 2020 and has been submitting claim for asylum. That application is still with the Home Office, and up to this point, there's no outcome yet. She's working with the solicitor. Next slide, please. Rani, next slide, please. So when we first met, I told her that every story matters, which is really important in what we do in Iact or talking therapy. We ensure that people's stories belong to them and they are the hero of the story. So we look at some of the cultural context, and we did look at the helplessness within the context of the culture that she came from, the beliefs around some of these things, the values that are being encouraged or enhanced, and also the limitations and the bodysomeness of the culture as well. As we can see, she was going through a very, very, very difficult times, and the culture was completely limited in terms of supporting her. In fact, she was the one perpetrating the abuse, instead of being the victim. And some of the factors really she been telling me is, when I see the clock ticking, that my husband is leaving work to come home, that's a big factor, a trigger factor that I begin to feel so much anxious, and my fear and everything begin to pump up, But she wasn't able to link with anybody because nobody listened to her. And so we really try to formulate that in our treatment. So we even had 3 sessions of assessment just to really have a comprehensive picture. So help-seeking ideology was also explored. And in most African contexts, and even in Southeast Asia, there's very limited description when we talk about depression or anxiety. And I will take you through to some of the perspectives that I have been working with. If you look at depression in the North African perspective, depression is described as madness, being lazy, craziness, mystery, state of sadness, and despair. So if you're going through this, where do you go for help? You don't even seek help through your clinical or professionals. You probably want to go to the mosque or the church or your pastor. If you look at the West African perception on or perspective on depression, broken heart, tormented, breakdown in the system, possessed by a devil or a demon, madness, confused, lacking in focus, burden, heart. My head has a problem and my heart is spoiled. So these are some of the description we have rather than depression, anxiety, PTSD, OCD, or a phobia. So these are some of the things that I brought to her notice, just to really look at the help-seeking ideology so that we can begin to look at that differently. And then we also look at the East African, where this lady is from. Depression is madness, craziness, dull, sad, odd, senseless, thinking too much, tired head, tired mind, head pain, and sickness of the soul. South
James,
African perception.
Just to warn you, you've got 1 minute left.
Described as problem of the heart, sickness, and the head. So what we did was to really formulate all of these things and put them into perspective for her to understand. And so these were the area that we deal with. And if we go to the next slide, you can see how these 2 pictures here, the one on my left is talking about the patient health questionnaire, the 9 questions. And this is what we use to measure the outcome in terms of the recovery. We started off with severe, and now we're in the mild range. On my right is the generalized anxiety scale. And again, we started off severe, now we're in mild range. So we've been able to really work together, and this lady seemed to engage well. The recovery, as you can see, is in progress, and we are very much close to ending treatment. And these are some of her own experiences in terms of feedback with me or working with talking therapies. Those key areas that really are highlighted, understanding my issues, and the reassurance, knowing the inclusiveness, and I think Rani mentioned that earlier, and also they feel hopeful and confident. So these were the areas that we really emphasize on. And this feedback suggests how this lady, how far she has come and where she is at this particular point in time. Her claim is still in process and treatment is still in process. And I can tell you that the recovery is really healthy. And I would like to thank you all, and we can now open to questions. Thank you.
James and Rani, thank you very much. Can you just unshare your screen? That's it. Fantastic presentation, both of you, really impressive stuff. One of the things that I've learned, and I think we're all learning about these cultural differences, because sometimes you think you know, and then when you sort of listen to someone, you find you don't understand, is how important it is to actually really get beneath the surface, because you find that people, don't come into our services for reasons that seem stupid at first, but when it's James, as you've been explaining, when we understand, it's really important to help us to tailor those services. Just before I invite Alex, so just one last thing, a question. Rani, I think you talked about this cultural sensitivity being spread outside talking therapies across the trust to our other services. Is that part of a sort of a pan trust initiative? Is this something which you're just pushing because you're very passionate about it?
I guess what I was talking about is that actually we've been feeding into the staff network to impact change more widely. So we've never used the term BAME. Doesn't mean anything to me. It's not a label that I use. It's not something that like I said, it's quite othering. I am Punjabi. I am I'm Desi. That's how I would describe myself. And actually, when it's seen as not great terminology, so we took that to the BAME network, and they really took that on board. They put it out to the membership about what terminology is better, and so that name is going to change. And then we were talking about what can we do for our staff in talking therapies who are from a diverse ethnic background themselves in order to kind of support them. And we said, actually, this is more than just us. This needs to go to the trust. And so kind of feeding into the network again. And James is facilitating fortnightly drop-in sessions for staff across the whole service. So that kind of linking in that the work that we're doing is having that kind of bigger change.
I think to add to that, Martin, basically I sit on the BME committee, and during a meeting we talk about how can we make our presence felt in the larger trust, if you like. And so one of these suggestions came from me that what about let's talk, and it became the Village Voice. This is just really extra support to what the EDI is doing anyway. So there's nothing really new, but this is really extending that forum, that village platform, if you like. And the attraction really is the Village Voice, because people get connected and people feel very relaxed and talk about anything, celebrations, issues, whatever, and support is given as well. And if there's any external need for support, we can go back to EDI and have those support being implemented. Otherwise, that's really the basic to this is let's talk, Village Voice.
James, thanks. We've got some questions, Alex.
Thank you very much, James and Rani. Excellent presentation. I just noticed on our agenda we have we have a paper on our community mental health survey from the CQC, and there's a couple of questions on talking therapies there. I know it's probably a side issue in terms of from the population of CMHTs being referred into Iact, but the question says, do you understand the talking therapies that you're now in or being accessed to? We're slightly below average on a reasonably high score on that, and I just wonder if you triangulate to all other kind of forms of feedback that you get, and be interested to get the kind of breakdown of ethnicity and the cultural backgrounds of those people. The other question is, have you been involved in your plan for talking therapies as well? And again, slightly below, but not a very weak scoring. And again, it's just some further intelligence perhaps to look through the cultural lens on.
Yeah, and I think there is that real understanding for stuff, but particularly for patients coming from a diverse ethnic background. So in my culture, there's no word for depression. In Punjabi, there's no word for depression, there's a word for crazy. And so actually when people are thinking about psychological therapy services, they're thinking about kind of feeling crazy, out of control, and that kind of that perspective of things. So they kind of want to engage in that sort of that perception of a service is really different. And there's a lot of education that we do within the grassroots community work in using culturally appropriate language. So talking about symptomology rather than labels, talking about how we can help rather than it's CBT or it's therapy. It's what change can we, what can we give to people? What help can we provide? What will that look like, rather than kind of more broader brushstrokes where people might have a much more psychological kind of understanding and background, where that's not necessarily there for a lot of communities. So that it's really kind of starting that work from the ground.
And just to add to that, Alex, it's really about the helplessness I mentioned earlier on. So our work is not just around us reaching out, it's also the community, grassroots community reaching out to us as well, because helplessness can really pacify people in the aspect of seeking help. They will probably say, my God destined me to be like this or this. So our work with faith leaders, grassroots community leaders and champions and community themselves, including the refugee group support in Reading and in the East, it's really helping them to really understand. So we have something like mental health first aid from a CBT perspective, so that it's really allowing them to perhaps challenge some of these cultural burdens that they really carry, which is really heavy on them in terms of seeking help. So it's a really two-way traffic. That's why we said mind the gap. So it's not just from our own spectacles, from their own spectacles as well.
Thank you, James.
We've got David and then Julian.
Thank you very, very much for the presentation. My question is going to be about health inequalities and access to the service. So we know a couple of things. We know that health inequalities, shockingly, have got worse in the last 10 years. We also know, as an NHS trust, that much of that is beyond our influence. So a lot of what causes health inequalities is about education and public health measures. So we've got to accept that there's a lot we can't do. However, the Nuffield Trust has shown in the last few months, what we've also known is that there's been an increasing health inequality around access to services. And they can evidence that the people who've done worse are those who were doing badly anyway. So actually, although it's really good that the young can use online services, they are the group that least needs them from a medical perspective. So my question is, what have you done, or what can we do to make sure that those who've become increasingly removed, unable to access our services, is improved? And I am thinking about online, but other measures.
Yeah, and that's what a lot of our grassroots community work is about, that actually people may be accessing their faith leader, they may be accessing a community group, and we, rather than sitting in our, the spaces that we've got, which is health settings, so hospitals and GP surgeries, myself and Jed, we're out in the community. We're running clinics where people can drop in and just ask us a little bit more about the service. We can talk to them about the service without that referral in. So that kind of sense of, we can have that discussion a little bit more. We can think about how the service might help you, but we're out in the community doing that. We are really kind of embedding ourselves in there to help the access routes. And access routes in as well as digital, and you can kind of refer in online or via your GP or other professionals. All these services can also signpost people to our service or refer in to us as well if those people need support. And so it's kind of looking at all those different aspects in terms of how we really it's not hard to reach communities. It's actually that that minoritized groups are, we need to be a bit more inventive and a bit more considerate about how we work to allow better access and changing our service around that. And that's what we've been working hard to do.
Yeah, I mean, I think it needs to be very systematic, doesn't it?
And just to add a little bit to that, if we have time, is we're actually including all of what you said, David, and the fact that we have all of these options can make life a lot better for people when they access our services. So it's not just one fit all. We face-to-face is actually now happening in talking therapies. I go to my own base 2 days a week, and I actually sit in the GP surgery alongside them, work with patients that are referred to us. So we have a lot of modalities, a lot of options, a lot of pathways. So it's developing all the time. But coming to your question around young people, Rani and I have been talking about starting a project. I'm starting a project in Reading along Oxford Road. Now we're actually targeting young men from the BAME background to really begin to understand how they reach out to their emotions. Because the lack of reaching their emotions is actually predisposing them to drug use, violence, and crime, and all of those things. So that's in the pipeline. So, but when I'm at the acre along Oxford Road, I also work alongside faith leaders and community heads. And so we work together, we collaborate. So if there's a case that need us, we discuss and then they refer those cases, either themselves or people themselves. So we are actually aware of all of those things. We also look externally as well.
Okay.
Yeah,
What is happening here.
it's a lot about building trust and relationships.
Yeah.
I think the time is against us now, but Julian, I think give him the last slot.
Oh, thank you. Thanks, James. Thanks, Rani. Really great presentation. A thought and a question, really. The thought is what I can't work out is whether we're best to organise ourselves in this way, which is to have this fantastic work you're doing for Iact, and then some equally fantastic work for diabetes, where we know we've got issues. You know, do you do it condition by condition, or is it something about engaging with these communities more broadly around breaking down boundaries? Do you see what I mean? Because we could have a presentation for a whole host of conditions, and we could start to look at health inequalities, and many of those will be the same issues. So in my head, it's thinking about how do we do this? And of course, there are other organisations and other health providers and services, Frimley and all the others, doing a bit of work in this space too. And I was just thinking about how we join it up. And then a practical question is, I know quite a bit about Iact because I chair the regional group. And what do we know about Iact? And I wonder whether it's helping health inequalities. So in Berkshire, we have above average levels of referrals compared to the norm. So you know, we're seeing more people. We're top in the country for acceptance. We don't turn anybody away. You're 100%. So that looks pretty good. We're upper quartile level for activity, so we see more people pound for pound, but we have very, very, very low levels of face-to-face contact. So we're seeing most people virtually. In fact, it was almost entirely virtually, and now the most recent data, we're about the 4th or 5th highest for not seeing people in the country face-to-face. Do you think that will help or hinder the work you're doing?
I think it really varies from person to person as to whether face-to-face suits them or not. We are, like we said, we are back in service. So James is, you know, we're both working clinically 2 days a week in doing face-to-face work, and that really works for some people, but for others it doesn't. So there's one of my clients who would never have been able to come in because of the logistics of actually accessing a physical space would have been just too much for her. And there's another client who would have really liked to come in for face-to-face, but her finances just mean that she cannot afford to travel to a specific place to access that service. So for some, actually, having a blended approach, I think, is much better because we can offer those options out, and people can do better. And pick what works better for them. So I don't think there's a hard and fast kind of outlook on whether one is better than the other, but we are certainly offering across the board. And I think therapy has worked really well online and digitally. When we had to go to that, we were able to do it really quite quickly and really quite smoothly to be able to offer that. But obviously that's not always going to suit everyone, and we do need to have the choice for clients to use what's best for them.
Okay, all right. I think we better move on. Rani and James, can I just repeat our thanks? It's fantastic work you're doing and a great presentation. And just to say that I think as a sort of lay person, if you're trying to engage with the health services from outside, it can seem very complex and difficult, even if you've lived with it all your life. And if you come from cultures which are different, and particularly if we don't understand necessarily those cultures, it must seem impenetrable. So I think the work you're doing is absolutely great. And you have our thanks for all you're doing. Please pass on our thanks to your colleagues. Great
Very
work.
welcome.
Thank you so much.
Thank you very much. We'll let you get back to work now.
Bye-bye.
Thank you. Bye, everyone. Bye.
Bye, everyone.
Okay, I thought that was great. A great presentation, really important piece of work. And so thank you for that. We better move on though. 6.1 is the community mental health benchmarking. Debbie.
Yeah, thank you. So this is the annual Cmht survey. I've summarised on the front sheet the key points. I would say is probably not a lot of difference in our scores over the last few years if you look at it over time. I do think it's an easier report to read this year. It is in a different format from the CQC, and I think that makes it easier. I'd always find it quite interesting. So we scored worse than last year on a question around people having specific time to discuss their needs, but then we scored higher than most on were we meeting people's needs and did they have time to have discussions. So I always find it quite a mixed bag when reading this. It's hard to pick out many specifics from it. For, obviously SMI and physical health checks featured in this as us not doing so well, and we know there's already a lot of work going on around that from a breakthrough perspective, and hopefully this year's scores will see an improvement in that with this cohort of staff. And the report has been shared with our colleagues in mental health services to have a look and see what else they want to do with the data, and I will leave it at that.
Thank you, Debbie. I mean, these sort of reports, unless there's something dramatically sort of awry, there's always quite difficult to interpret some of the trends, I think, up and down. And clearly you've highlighted the physical health check thing, which came out very clearly. But I guess that the trick is trying to look at the trends and see if there's some things which you can put together to focus our attention on improvement. Anyway, it's a very comprehensive report. Julian's got his hand up.
Yeah, just to say, Martin, I mean, if you look at it objectively nationally, so just to take us out of it, the survey findings are quite disappointing, aren't they? If you compare them to other areas of healthcare we provide, you'd find much higher scores. So generally, we know public perception and this survey has generally scored lower for 10, 15 years, really. So we've kind of struggled to get those sort of scores up. Both in Berkshire Healthcare and generally in other places, with some exceptions, you know, and we've been sort of middle of the pack. Even when we've been seen to improve in other areas as an organisation, this survey hasn't really changed much, which is quite interesting. I don't know if I've quite got the answer, but my sense is that I think we might be able to get a little bit more granular detail and real-time detail from the new patient experience tool that we've got when we start to be able to look at which part of mental health services people are more satisfied, less satisfied, and what are the main causes of that, so we can perhaps get a bit more forensic. Otherwise it's quite hard to think actually from this survey you'll do X, Y and Z and suddenly it'll all improve. Yeah. So I think that's the value of what we've got over the next 6 or 9 months, started to really think about which element of our mental health provision we could really change to make the biggest difference.
That's great. Thank you for that. Any other comments, Debbie? Okay, Deb, well, thanks so much. We'll move on perhaps to patient. Oh, sorry. Naomi, sorry, I missed you.
It's fine, Mark. Thank you. Yeah, just a quick one, and I might be trying to sort of join too many dots inappropriately here, Julian, but it occurred to me that we are an outstanding trust, and that's measured to in a way which is highly detailed. Is there any merit in trying to understand better how we might interpret the results from this survey alongside the sort of equivalent measure, if there is one, as it relates to CQC outcomes. Did I phrase that right? Do you understand what I'm saying? I'm just sort of thinking, you know, I can see we can compare and contrast using this survey ourselves against other trusts, some of whom will not be outstanding. So I'm just trying to understand how is that worthy of any form of interpretation?
We've tried, Naomi, without much success in the past. So sometimes an organisation has not got as good reputation has actually scored better, and vice versa. So it's quite difficult to do that, if I'm honest with you. And of course, the numbers involved, you know, compared to the patients we see are quite small in terms of, because it's a really big survey. So one of those that will be a bit self-selecting. I mean, I think I think it reflects generally people's levels of satisfaction. So we know from complaints and our patient experience that there are parts of our portfolio, mental health tends to be the bit where there is less satisfaction. That's nationally the case. As I say, my sense is that, you know, the new tool, if it allows us to drill into those particular teams, those particular areas, then that's probably our best bet of driving up improvement, I think, because we'll have a bit more clarity, and which I think what you're saying is, can we get that clarity? And we do struggle with this survey, but I do think we can't keep watching it year on year. So I do think this is an opportunity for us with the new tool to get under the skin of it.
Good, thanks, Julian, brilliant.
Okay. If there's no more questions, we'll move on to a patient experience report, Debbie, which I think is showing roughly the same pattern as we normally see. Is that right?
Yes, there was nothing in particular I wanted to pull out from this report. The most exciting thing about it is the fact that we have started using the new tool now, and we will change. This report will look different from Q1. We're going to give Q4 for it to really be embedded, and for services to start really using it and being able to do something with the data. I've put into an appendix a few of the snapshots of the dashboard, so you can see some of the data that we are going to be able to look at and manipulate and use. I think it's really positive. I was looking this morning and we've had, I think, 466 people report on the tool now, use the tool, and only 9 of them haven't put comments. So pretty much most people that are going in and actually using the tool are putting comments around review and improvement, or being positive, whichever way it is. But I think that's really positive that patients are taking the time to actually give some free text narrative, and they're not just ticking a box and giving a score for each of the stars, which is the richness of the data that we'll be able to use to actually make some service improvements. So yeah, that's all I wanted to say, really.
Okay, thank you for that. Anything else for Debbie? No. Just to note, the 15. Oh, sorry, Naomi.
Sorry, thanks, Marcy. Yeah, Debbie, just an inquiry about, and you might have covered this historically, so forgive me, this kind of reporting cadence for this new tool. There'll naturally be a period of time of bedding it in and, you know, nailing it down and making it hum, so to speak, and then bringing the data to the board. What sort of regularity do you envisage there?
It will be quarterly, the same as the patient experience tool. It's just we will historically, this patient experience report has focused very heavily on the complaints elements of stuff and that formal reporting, and we want it to be much more reflective of the totality of the patient experience and the complements, areas for improvement, and what we're actually doing about it. So I'm not going to change the reporting timing, just the look of the report.
Excellent.
Using that new data.
Thanks, Debbie.
Okay. Anything else? Didn't mean to rush you. Okay. Infection prevention and control, board assurance, Debbie. 6.3.
Yeah, so I've just put this on because there's a requirement for this to go to the board every now and again, and it was quite radically updated. Oh, Christmas Eve we got it. That was my Christmas present. So it really is here for information. The thing that we are I call it a gap, but the gap that we're working most on at the moment is just ensuring that everybody has who's fit tested for an FFP3 mask has that recorded onto ESR. There's now the ability to record that into ESR, and we do have a requirement by CQC and others to have a central record of our fit testing and who can wear an FFP3. So that's the bit that we're working on. I know this has focused quite a lot on the board being aware that we have enough staff trained to be with use of FFP3. I'm confident that we do, but it's worth noting that here and say we're just updating our central records and everything else. There's nothing else really that I'm concerned about in terms of we are following the national guidance and have everything in place around IPC measures.
Okay, thank you. Any questions for Debbie? No, thank you very much. Let's hope your next Christmas isn't upset by rewriting these things. Fingers crossed. Okay, the next, moving on to executive report, item 7. We'll do our normal thing of, I think, just questions, Julian, unless you've... Okay, anyone got any questions on the report? I think the COVID vaccination issue is one which we await the government's decision before anything happens. So we just carry on as normal at the moment. Naomi.
Thanks, Martin. Just as we were speaking then, I was trying to see whether or not the item I have on my mind is actually in your report, Julian. So, but I'll ask the question anyway. It's actually about head office. I think we sort of get to it somewhere on the agenda. I think I'm mindful that our lease on our current head office is going to expire pretty shortly, I think March or thereabouts. And then it looks like there's going to be a gap between then and which may be renewed, I think. I'm just wondering about the contingency plan in the event that the lease was not renewed, which I think is not a big risk. But just if it wasn't, do we have a contingency as we're waiting for the next the next office to become available?
Yeah, we have got a contingency, and if it's all right with you, Naomi, it is a later item. So
okay,
if we could pick it up there, there is some sort of commercially sensitive stuff as well
okay,
in terms of the lease and bits and pieces. So we're going to quite likely deal with just that bit in private, just because of the potential commercial bits around. We're in the process of negotiating some leases, but yeah, we have got it in hand. So that's the sort of public message and the message to our colleagues, and we'll pick it up in part 2 if that's all right.
got it.
Thank you.
Thank you. And we have on page 178 the modern day slavery statement, which we're required to approve. It's a detailed paper which is attached. Has anyone got any problems with it? Happy we approve that? Okay, thank you very much. Okay, finance report. Paul, item 8.
Thanks, Martin. So just start by giving a bit of context as we sort of head into the latter part of the financial year in terms of where we're looking at and where the system numbers are heading at the moment. Obviously, the board will be aware that there's been significant levels of additional funding that have been pumped into the NHS this year. And I think probably quite rightly, there's some concern nationally on the level of surplus that potentially the NHS is going to post at the end of this year, especially given how difficult the funding settlement was to be agreed with Treasury. Equally, we've been given a steer from NHSI and E that what they're not expecting and don't want is any material surprises in month 12 in terms of numbers swinging beneficially. So we've tried as we can to get a more accurate view on where we think we're going to head towards the end of this financial year and put that in the report. In terms of Frimley, they're already indicating that they're going to be around 10 million in surplus and potentially north of that. Bob had originally put a planned deficit in for the second half of this year of 11 million, and that has now moved to break even with some of the acutes and ourselves improving our position. And again, there's some upward risk on that number as we move through Q4. So I guess apart from planning, a lot of the focus of the finance community at the moment is how we manage our allocations at year end, to make sure we mitigate as much as we can and protect as much of the funding as we can as we move into 22-23. So I just now turn to the report, just picking up some of the key headlines. Still continuing to report strong financial position for this financial year, surplus of 700, which is 1.5 million better than planned. As I said, we've done some work on where we think we're going to land at the end of this financial year, and we think we're, given where we are now and what we think we're going to spend before the end of this year, we've improved our forecast by £1 million, so that would take us to break even for H2, second half of the year, and take us to £1 million surplus for the end of the year overall. One point just to note on income, it's mentioned in there, and I think it was a direct question at the board last month around the risk on the deferred income. So I think we've previously been reporting that we're carrying quite high levels of deferred income in terms of spending review and service development funding that we've been unable to spend this year. The intention was to work with the commissioners and defer as much of this as we could into next financial year. The centre over the past couple of weeks have sent through guidance that they intend to claw back any unspent spending review and service development allocations relating to mental health services. So what this means is that we're effectively having to go through each of those individual allocations with the commissioners to agree the accounting treatment on each. And obviously we're all got a vested interest in terms of trying to protect as much of this income as we can, carry forward on the balance sheet as much as we can, to mitigate, genuinely mitigate the losses and avoid returning any income to the centre that obviously we would be able to utilise next financial year. In terms of risk, we're probably looking at about 3 to 4 million in totality across Bob and Frimley. But like I say, we're working through this, and this is adding to some of the complexity around forecasting where we think we're going to be at the end of this financial year. From an expenditure perspective, we're still continuing to incur lower COVID costs than income that we've received. That's continuing. Workforce costs have increased slightly, but that's more an upward trend in temporary staffing usage. And obviously during December we saw more cover for sickness, continued vacancies, as well as annual leave cover. We're also seeing more services that are having to resort to paying premium rates for staffing to attend services. So we're keeping an eye on that in context of what it does for numbers for next year. From capital perspective, we're 2 million behind plan year to date, which seems quite sizable given where we are in the year. But we've got a number of schemes that are due to complete in March, and if they all complete as planned, we should spend in line with our ICS capital control total for the year. And goes without saying that given the deferred income position and current position on capital, we're still holding a strong cash balance at over 56 million. Happy to take any questions.
Thank you, Paul. The thing that I always worry about and is with this very complex funding and position, it is keeping a close eye on what the underlying position is, as it were, because we've got COVID things, we've got these additional funds you talked about, we've got the 2 ICS. There's quite a complex sort of range of balancing lots of different numbers, and I always like to have a very clear picture, if we can, of what's underneath that. You know, if we're carrying on as normal, as it were, in a steady state, what would it really look like? I'm not asking for any answers now, but it seems to me that's a focus we need to keep, because otherwise we can get rather too involved, and I understand the importance of doing it, too involved in managing the tactical stuff, as it were, and have our eye off the strategic, which might actually come back and bite us in the longer term. Sorry, it's a rather philosophical and motherhood and apple pie comment, but Alex has got a much better question to ask, I think. So
yeah, it's not a question, Paul. It's a point for the board to think about, actually, and one for us to raise in public, really. So it's what does this look like if mental health allocations are being clawed back, whilst there is a major focus on physical health, elective recovery? Are those allocations for mental health, which was to progress our development of mental health services, going to come back to systems next year? Because if they don't, I just wonder what message we're putting up the line alongside this parity, this balance with physical health recovery that needs to happen post-COVID. What messaging is going up? Because it doesn't feel right. I accept that our workforce market and COVID pandemic has constrained our recruitment to those funds, but those funds need to be made available to mental health.
That's a good point, Paul. Do you have a comment, Paul?
Yeah, no, I mean, I'd absolutely agree, and I think it's been noted certainly on some of the national calls that it feels like, why is mental health in the focus in terms of the clawback, because other services did receive additional funding. I think where they're potentially looking at SDF, we know we've got, or we're starting to get line of sight on new SDF allocations and replacement allocations for next year. The spending review, I guess they feel because it was non-recurrent for this year that there's legitimacy in terms of clawing back what they couldn't spend. But like I say, it does feel like mental health is being penalised to some degree.
Thank you for raising it, Alex. We need to keep a watch on this, don't we, over the coming months. I quite agree.
I think one of the things is that sort of Claire Murdoch talks about this, obviously, as a national lead for it, and whether we've been creative enough, because one of the reasons for the underspend is actually getting the workforce to be able to do these kind of new roles that have been rolled out at sort of pace. In physical healthcare, quite a lot of the expenditure has gone, for example, to buy additional capacity in private hospitals, you know, to contract with that. And I guess the challenge that we need to look at ourselves is, are we using every available bit of capacity for mental health that's available, private and voluntary sector? And is there something that we can perhaps badge against some of that stuff, which may not be entirely textbook and in line with the exact expressed wishes, but as close as possible? And is that better than losing the money altogether? So a question about just thinking about what might be in scope and what we might need to do that might be the equivalent of what's happening in physical healthcare. What would our equivalent be to sort of try and find that additional capacity?
I think it's a very important point, and actually I put it slightly differently. It's not about sort of losing the money; it's losing the ability to treat patients, isn't it?
Yeah, one of the things, aren't they?
We have to be more, but we have to be sort of really inventive as to how we can find ways of using that money to help our patients, even if it's not quite in the sort of conventional way. I think that's really important. Anything else for Paul?
No, I mean, if I just come back on, I mean, I think Julian's absolutely right. I think we did start this year looking at alternative providers where we didn't have capacity, certainly around ADHD and autism, and we did start trying to buy up that capacity. I think the problem that we ran into is so did everybody else. So the market got saturated very, very quickly in terms of the amount of capacity that was out there. But it's certainly what we have started to do this year, which is look beyond just, you know, if we can't recruit to it, how do we spend it?
Yeah. Okay. Anything else on finance? No. Can we go on to the performance report then, please, Paul?
Yeah, happy to. I'd like to take the report as read and just highlight a couple of areas. So obviously a lot of the indicators that were read are still reporting red. If I just look at falls, it's increased slightly. Just the narrative there, just noting sort of 80% of the falls are on wards with high occupancy over 80%, and 82% of the falls unwitnessed. I know we're doing some work, certainly at QPEGs we discussed around looking at the metrics and level of harm that's caused. So of all of the falls this month, none resulted in any severe or moderate harm to patients. Self-harm incidents fell, which was encouraging, and as ever, devil is in the detail. Over 50, or just short of 50% of the incidents on one ward, Bluebell, and all of those incidents related to 2 patients. Fire evacuation is creeping steadily up towards the 95% target, and we continue to work to try and get to that. And then 2 interlinked, so acute length of stay in mental health beds remains high at 58, and obviously linked our inappropriate out of area placements. I think we'd already broke a breach trajectory at the end of the first month of the quarter, so no surprise at the end of Q3 we've finished ahead of the trajectory for that quarter. The other thing just probably to keep an eye on is obviously staff turnover is over the 16% target, and has been for the whole of Q3, so one that we will need to keep an eye on, but I don't think it'll be any surprise given what's been reported to the board previously. But happy to take any questions.
Questions for Paul? I think it's a pretty clear report anyway. We can see it's I think some of these things about the detail are important to understand, like your comment about Bluebell Ward, you know, the self-harm attributed to 2 patients. When you see the overall things, you know, you need to get a bit of detail behind to put it in context. I guess the staff turnover is a continuing problem for us, and we need to watch that carefully. There aren't a lot of staff around who are just going to be waiting for a job. Okay. Naomi, 8.2. FIP, anything you wish to raise?
Thank you, Martin. I can be really brief, given that in-year financial performance we've just covered, and we've also just covered the performance scorecard. So really sort of just a couple of other highlights from our last FIP meeting. We had an excellent presentation, a report back from Jane Nicholson on our human resources casework report. So this is some new process, some new policy, some new procedure, new approach to the way in which disciplinary activities are undertaken. And the work that was done, the period that was reported on was April 2021 through September 2021. Where that new process has been embedded, and all the indicators are that it's working extremely well. In particular, the number of cases has gone down, you know, in a statistically important way, and this really has been achieved through actually what I would describe as being taking a far more holistic view of the incidents that give rise to disciplinary action. And an overall far more empathetic kind of mindset in doing so. So all to the good. I would emphasise that this is part and parcel of our renewed, reinvigorated approach to a just culture, and also emphasise that Frimley Health and Care Integrated Care System are doing a more specific piece of work in this particular domain, looking at our BAME community who are overrepresented when it comes to disciplinary activities. So really trying to get under the skins of why that is and how it happens. So it's a really excellent piece of work which is going extremely well, and we'll see more of that. I've asked Jane if she wouldn't mind bringing it back to us, you know, at a point in time where she feels it's worthy of reporting, and it would be good, I think, for the main board to see that work going forward. And the only other piece I wanted to emphasise, but of course we looked at some of the draft financial planning activities that are going on as we speak in regard to the next financial year, so 2022-23, and we're going to see more of that in our next session, so I won't dwell on it. It's simply true to say that the emphasis in our review is about you know, reduced levels of income as we move into the new financial year, as COVID monies and others disappear, and inflationary pressures, and then, you know, a deeper conversation, and there's more to come on this in terms of how we will close the gap, because there will be one. And with that, any questions?
No, I felt I think the area of just culture is quite an interesting one, perhaps not for discussion now, but in due course, because although I understand that our initial results are showing a reduction in formal disciplinaries, it isn't affecting the difference between different ethnic characteristics, the proportions, I think. So I think there's some quite interesting work to be done there to understand further, you know, what we need to do to try and address that problem. But Jane will be addressing it, I'm sure. So, well, I know she is. So it's, okay, anything else?
Not from me, thank you, Martin.
No, any questions for Naomi? Okay, so we move on then to, I think it's now the Health and Wellbeing Update Report.
I'll
Alex,
take that, Martin.
I think you're going to lead on that.
Yeah, thank you. And with thanks to Mark for his steer and support to Steph in overview of our plans. This report serves to update on our health and wellbeing activity for staff. You can see good progress being made against plans. We did the wellbeing national diagnostic tool, which has set our plan for 22-23. A good mix of system work going on and our own work internally in the organisation. And I think I would say health and wellbeing for staff doesn't sit as a silo. We are connecting this up around reward, recognition, the reconnecting events being a very clear example of how reward and recognition connects to well-being. So teams reconnecting back in the summer and autumn during a very intense period, taking some time out for team and individual well-being. So that was really good. I think we also reflect on discussion with teams that communication about our wellbeing offer, we can't do enough of it, and we need to have a look at Nexus in terms of ease of use of getting to that offer. We know that the wellbeing hubs that have been provided as some of our more in-depth and impactful wellbeing support to teams is effective. The feedback on that is really good. It's about the communication, and we continue to do that, and we'll take that into our planning as we go forward. So very happy to take any questions on this.
Fine. Sounds like it's transitioning well from the COVID issues into a core part of the trust. Aileen.
Hi, Alex. I just had a really quick question, please, about the plan for February, and that was the one about introducing buying and selling of annual leave. I just wondered, we are likely to do that, presumably. I thought, to be honest, I actually thought we already did that, so I didn't know if we've discussed it or touched on it previously. Yeah, so that was just a question.
We are likely to do it, as you know, staff continue to ask for that option. Others are doing it. We're going to communicate with the trust about that soon.
Right, okay, cool. All right then, thank you.
Thank you.
Mark.
Yeah, it was a good report from Steph and Hardip in terms of the work that's underway. One of the things that came up at the governor's meeting last week, and I think is going to be very and increasingly relevant over the coming months, is the financial challenges and hardship our staff are going to face, with both utilities, energy bills and general cost of living racing away from them. And I was just wondering, Alex, can you tell us in terms of what packages or thoughts are being put together in terms of the support that can be given to staff to help them over these coming months in terms of that from a wellbeing perspective?
Yeah, I think it's a really good question, Mark, and we see things around hardship appearing quite regularly, actually. My sense is we need to refresh the communication around what support is available outside the trust, and also firm up our framework around hardship support inside the trust. And by that, I mean taking case by case hardship requests where we're able to provide interest-free loans, if you like, to colleagues. If there's particular hardship, we can also make awards from charitable funds that may be non-repayable. It will depend on the type of case that we have. So there will be a mix of signposting to support and the support that we can provide as a public sector body around hardship. And I think we could do with clarifying our approach to that and communicate it. Jane's here.
Jane.
I just wanted to add one thing. I wasn't sure if you'd mention it, Alex. And one of the key areas that we've identified where people suffer hardship is if they're on some form of top-up benefits. So we are looking at now changing the pay date, so we have a more consistent pay date, and that will help people be able to plan for their benefits better. We are one of the outliers in trusts locally that don't offer a fixed pay date, but we are going to be moving from next financial year to a fixed pay date on the 28th.
Yeah, so that will certainly help with cash flow, won't it, for those impacted? Thanks, Jane.
Yeah.
Okay, thank you. Mahmouda. Mahmouda, you there?
Sorry,
That's all right.
I'm just wondering how the Wellbeing Champions Network is progressing. I think it's because it's just started, hasn't it? Started in January, all right?
And this is a Bob initiative. Jane, are you able to provide any information on that? Jane?
You there, Jane? You're on mute.
Yeah, sorry, I just had a phone call from my son's school asking to go and pick him up. Apologies. Oh. It's not, I'll talk to his dad in a minute. Yeah, sorry, what was the question?
The Wellbeing Champions.
Sorry. Yeah.
Sorry, Mahmouda.
It's okay.
Sorry, the question about sorry, what was the full question?
Mahmouda, go ahead.
Yeah, so the question was in relation to the Wellbeing Champions Network, and I know it's just started in January, but how it's panning out.
Okay, yeah. So we were really pleased with the launch of the Wellbeing Champions, and again, thank you, very much to Mark who helped us to launch that. So the way that we're using the Wellbeing Champions is very much around where we want to deepen the understanding of the wellbeing offer, because we are very conscious that some staff aren't aware of the wellbeing offer. But it's also ensuring that we've got people who are skilled in certain things. So, for example, we're offering mental health practitioner training. They would be the first people that we would offer that type of work to, or that type of training to. And the other way that we're using the Wellbeing Champions is that we've started now to get our first international nurses into the organisation. So the first 2 have landed, and we're making sure that the Wellbeing champion in their particular area knows who they are and proactively reaches out to them to check on their wellbeing, because we do know this will be a difficult transition for many of them arriving in a new country.
Okay, thank you very much.
Does that give a feel?
Yeah, thank you.
Okay, any other comments? Okay, shall we move on then to 9.1, the Trust Green Plan, and welcome Jane.
Hi everyone, sorry. I will try and share my screen, but you've got the papers in front of you. Just to put it in context, this is our first Green Plan for 2022-25. It's a requirement of the long-term plan and of the legislation. So you've got the whole plan. I don't expect to go through all of that with you now. I've got a few slides that I just want to go through. But any comments you have on that would be really gratefully received, because it's not the finished article. That's why it's got draft over it, because we wanted your opinion. One of the parts of this process is to bring this to the board, to get the board to sign off the plan. So obviously your input into it's going to be really important. And we'll need to work up the action plan. The other thing is that I'll need to bring it back every year to you to let you know where we've got to on it. The other thing is, on one of the pages, you'll see that there's a question mark, if you've read through, about when we want to achieve this by. And the NHS expect us to achieve it by 2045. And I wondered as a trust whether we wanted to be more ambitious than that. So it was deliberately left blank as question mark. So just a thought for you to think about, do we want to be more ambitious than 2045 in terms of those direct things that we can influence? Okay, I'll try and share my screen now. This will be interesting. Let me have a look. Sorry. Can you see that?
You've got 2 pages up.
All right. Okay. Let me just go into the one that I should have up. Is that right now?
You just make that a slideshow. Oh, there we go.
Yeah.
You're getting there. One more.
One more click, and you should have it there.
Excellent.
Yes?
Well done.
Okay. All right then. So I'll just go through because the first few pages are just about the drivers for change, etc. And you'll all know about what those are. I'm not going to go through that with you. We all know that the world is warming and we need to do something about it. And the NHS contributes 5% to that national warming. So we need to get our own act into gear. So if I go down past the drivers for change and just what we've done, because maybe you don't know what we've already done. Although this is our first green plan, we aren't new to this. So we've already driven out any of our single-use plastic that we can. We've eliminated that. We've directly managed our contracts, so there's zero waste to landfill. We've improved our recycling rates across the trust. We've increased our clinical waste segregation, and we've established challenging targets going forward. And they'll see those on the action plan. But we're not new to this, so we're already on that journey, and that's important for you to remember.
Jane, can I just interrupt? You know, there's zero waste to landfill. I think that's qualified. I think that's zero clinical waste. I don't think it's any of our general rubbish yet at this stage.
No, it's clinical. Yeah, it is clinical waste to landfill. Sorry, thanks, Julian. We've done quite a lot on green sites. So we've got a really good therapy garden project at the at West Berkshire Community Hospital. It provides food for catering. So it's cutting down the mileage on getting food to our sites. So again, it's cutting down our CO2 emissions. It's providing a really good outside space for staff and patients. It won a Sustainability Health and Care Award for Green Space in 2018. And we planted a tiny forest at West Berkshire Community Hospital last year through DEFRA funding. So not many of those around, but it's growing, and we hope it'll grow really nicely this next year. COVID has done us a real favour in terms of vehicles and remote working. We were already on a remote working journey prior to COVID, but it's really driven that, and you can see that from these graphs here in terms of what that means in terms of mileage, cost, and in terms of CO2 emissions. Would we have done it this quickly had we not have had COVID? Probably not. It's driven us to do something very differently. But what we do know is we won't be returning to how we worked previously. So this hybrid model of working will by definition help in terms of our CO2 emissions and our sustainability. We've seen a big increase in non-face-to-face, and it was interesting, Julian, you asked a question on talking therapies and around that return to face-to-face, because it doesn't suit everyone to do this virtually. But as they say, having a range of modalities is really helpful, because not everybody wants to do face-to-face either. So I think it's not returning to all face-to-face is not a bad thing. In terms of our office workers and our back office, again, that sense of team, we will need to return to the offices for some meetings, but not for everything. So we do think this will continue to be kept down, really. We're getting some electric charging points. We've already got some over at Wokingham and St Mark's, Churchill House. We're going to be getting them elsewhere throughout the trust. And we are having a conversation about our lease car scheme and whether or not we can incentivise the use of either hybrid or electrical vehicles in the next year. So at the moment we don't do that, but it would make sense to look at that as an option. In terms of energy, as you can see, there's quite an impressive improvement there on our total carbon gas and our total carbon electricity. We've made some real changes there over the last 4 or 5 years. So this year it'll be even better. And that's quite good when you think about some of the sites we operate out of. They're not the greatest sites. We don't own them all. So to actually be able to make this difference is quite interesting. And then this is, I find this really helpful to put it into perspective where we are. So only 24% of our what we use is within our control in terms of our carbon footprint, and that's the bits that we intend to work on this year and the next 3 years. But those things that are within influence, we also need to look at, and so those are the footprint plus. And so not only do we need to look at the travel of our staff, we also need to look at the travel of our patients, and obviously working virtually helps with that, but also looking at whether or not we go out to patients more instead of them always coming to us. So I know that we've bought buses to get out to hard to reach communities, and whether we need to do more of that. Then this is our rest of our plan for Journey into Green and what we need to do. And those are our 5 strategic goals that are set within the plan. And you'll see that when you read the plan. And then these are our action plans. I've just taken these out of the report and just to show you some areas that we're looking at, but I won't go through that. Any questions? I've just romped through that, but
Jane, that's fine. If you could unshare the screen,
I
then we
will
can
unshare. Where do I go to unshare the screen, Martin? There you go.
Oh, I don't know. I have to ask my grandson that.
See, if I should have done that earlier because it wasn't as bad. I was more anxious about sharing the screen than I was about doing the presentation, which is not right.
It's fine.
Okay.
It's fine.
Okay.
Okay. Look, it's an important topic. Can I just say, just before I invite comments and questions, when you're as old as I am and you see your grandchildren, you know, and you try and calibrate your views to theirs, I'm a great fan of you know, environmental issues, but when you talk to the youngsters, it isn't sort of an issue, it's just an expectation. They're a different world, a different place, like they are in many things, you know, diversity, for example. So I think our younger staff coming up will be expecting, regardless of the moral issue, will be expecting us to operate in a way which they see as responsible, environmentally responsible, which just adds a sort of pressure to not take too long over this, otherwise we'll be seen as a dinosaur. But
I think that's an interesting point as well, Martin, because it could be an offer to actually bring people in, because you're right, they are socially more conscious than many of the older generations. So it is something that we should shout out about, really. It's something we're doing. It's important.
Thank you. Now Mark and then Alex, I think.
Thanks, Martin. Thanks ever so much, Jane. And rather like Martin, this is a subject quite close to my heart, so I was pleased to see the paper in today's pack. A couple of questions from me. First of all, I was in the fortunate position last week of having my laptop replaced. And when I was going through the handover with the member staff, I inquired as to what would be happening to the redundant kit that is going back to head office. And the response that I got was a little bit unclear, to say the least, and it almost sounded as if it was going to end up going to landfill or some third party that wasn't recycling. And I couldn't see in the report where IT and all of our kit, which we do cycle on a fairly regular basis, fits into that. So I just wondered if you could expand a little for me.
As far as I'm aware, Mark, we do recycle most of our kit, but I can take that back because it isn't in there and it should be in there. You're quite right, because that is within our gift to do something about. So yeah, I'll definitely pick that up with Mark Davidson and Dave Aston to see what we can do about that if we're not. But my understanding is we do recycle, and that's why they chase all of the kit down to get it back to do that recycling.
That's great. I'd really be keen to hear the response on that, because I have had involvement in the past in terms of having more and more percentage-wise recycled each year, and it is possible to do that.
Yeah.
The other aspect that for me was missing from the paper was that it was taking the trust quite rightly in isolation, but for me the real opportunity in terms of making an impact on green issues and on the environment is where we collaborate with others. And I do see that with the ICSs emerging over the coming years, our opportunity to make the sum of those parts far greater in terms of the impact is a tremendous opportunity. And I'm just wondering, where do we get our voice raised on this subject and pushed up the ICS agenda?
Okay, in terms of that, the ICS, both ICSs have requested a copy of our green plan, which we've shared with them in its draft form. We've also met with Oxford Health to look at doing some collaboration around the plan. So although we had a deadline to submit by January in terms of a draft, but we've met with Oxford and we intend to do some more work with them, because in terms of those offers to staff, in terms of training, any procurement, that doing it together is going to be more beneficial than doing it individually. So we've reached out to Oxford Health. We've also we will reach out to Surrey and Borders on the other side, but the ICSs are looking at doing this as a collective, and so that's why they've taken the plans in. So we'll be working with those. So although it's a Berkshire healthcare plan, it will align with those plans, and we'll work together in terms of those pieces, like I say, procurement, in terms of any savings, any staff training, and any comms. We can work very much together on those.
Yeah, I think that's right, Mark. I think when you use ICS, we're perhaps using it in its widest sense. And I think probably if you think about who's consuming all this stuff, it's providers, aren't they? They're the big, Oxford University Hospitals, huge organisation, huge amounts of it'll be a provider collaborative within the ICS, probably. The ICS probably will have to be expected to have its own green plan, but where will the rubber hit the road? And I think that will be, thinking about sort of catering contracts, thinking about bringing things more local and doing that at scale. So this type of stuff that Martin sometimes talks about is chairs about, which is, can we collaborate on something behind the scenes here that would give us scale and also give us a more sustainable footprint. So I think you're right, Mark. There will be stuff to done, but I think it will be at provider collaborative level within the ICS, because we're the consumers of the mileage and all the food and the travel and the medications and all those things that rack up the greenhouse gases.
Good, thank you.
And I think what we can do, Mark, is share some of the stuff we've done on remote working, for example, because we are leading the field in terms of that remote working offer, and other trusts are interested in that. So we have shared what we've got to date with them, because that will sit very firmly in this space in terms of sustainability.
Thank you. Alex.
Yeah, it's building on the theme of working with others and actually holding others to account for their own plans, because we know that I think it's around 60% of the NHS carbon impact is in supply chain. And so we work with very big supply chain partners, with NHS supply chain and other major suppliers around us. So there's that piece about understanding what others are doing to contribute to the overall system impact, and that we own part of that and hold others to account. And then another piece is the partnership opportunity around social value. We know we're going to need to invest quite significantly for sustainability in various areas, and what might the opportunities be with our commercial partners, other industry partners, that could become charitable, that could become joint ventures, that could bring investment in. Quite an exciting area for partnership development potentially.
Thank you very much, Alex. Naomi. Oh, sorry, Jane, did you want to come back?
No, I was just saying thank you, Alex.
Okay. Always a wise thing to do, Jane.
Yeah. Keep it sweet, yeah.
Naomi.
Thank you, Jane. I'm just so delighted we now have a plan. It's just really, I mean, that for me is the first point of note, and I like the fact that the action plan, which you've included in the pre-read, is incredibly detailed. It's very clear that in the majority of the actions that you've described are quite high level. They're quite lofty as well, and they all come across as quite there'll be a level of detail below that to actually execute. And the point has already been made about resourcing that, so getting the action plan done, and creating some momentum across that. We will not do this alone. We just won't. And so that point has already been made, and I'm delighted that the opportunity will reside there across the ICS in the way that other folks have described. A couple of thoughts, really, more than anything else here, Jane. And I know this is a conversation that has no end. Actually, we will just keep talking about this and refining the plan and the strategy going forward. One thought is, potentially taking a sort of risk-based approach, and I won't go into any detail about my more detailed thinking around that. You and I could converse, or alongside Alex offline if we need. But there, it's the obvious thing. We know why this is important, and we know potentially what climate change could do that would impact us in a negative way and our patients, and therefore describing that from a risk perspective might be a way to go. It's just a suggestion. Another is around this. You touched on it actually in the front end of the conversation around ambition. It strikes me in spades when I look at the NHS, us as a trust specifically, and across the NHS, that there are some opportunities that feel rather unexplored to me. So 2 of them in particular. We have a lot of disposable stuff, and I'll put the clinical waste to one side for the moment because that's a specialist area. But we have a lot of stuff that gets thrown away. Face masks are an obvious one that would come front and centre, wouldn't it? There are things going on in the UK and across the globe to deal with disposed of face masks. It is within our gift to work, to uncover what those are, and potentially there may be initiatives going on locally that we could dip into. So again, that speaks powerfully to the point about who can we work with, potentially in the local community, to create some innovation around recycling, not just masks, but aprons, gowns, etc., and get deeply knowledgeable about where that stuff goes. It is not enough for us to say, well, we recycle our waste. It is incumbent upon us to say we recycle our waste, and this is how we do it, and this is where it ends up. This is what we mean by recycling. It's the concept of circularity. Yeah. Another would be, and I say this cautiously because it's something that I think is new in a global sense, is uniforms. We as the NHS will be using uniforms in a way which many institutions or organisations don't. In other words, at scale. So I think it would be interesting to better understand at board level where do we source our uniforms from. My emphasis here is knowing that the clothing industry is a massive blot on the landscape when it comes to sustainability. We know that. So when we look at that through our own lens, where do our uniforms come from? How do we supply those to our staff? And when their usage has been exhausted, where do they go to? And is there a different model? There is, and I'm labouring the point here, so forgive me, but it's such interesting territory. There is work going on in the States at the moment in the hotel industry to rethink the whole way in which uniforms are provided, supplied, recycled, and so on, and a kind of lease model rather than a purchase and supply model. So it's those kinds of things, thinking beyond the obvious, that I think we could be quite good at. I'm going to stop there because I probably said way too much.
You're like I was when I first took this on, Naomi.
Yeah,
I just couldn't stop, but it's really, really good. You can do so much with it. So I would really appreciate a conversation offline to go through, because those are really interesting points, and certainly Paul Harrison, who leads on this, potentially has thought of a lot of these things and hasn't been able to do them on his own. So I think if we can start to harness his thoughts alongside ours, and then I've got to meet with Paul to put figures against this. He's quite keen that I meet with him to cost this one up, and then we can work from there. But yeah, any ideas are really gratefully received, because there's so much that we can do. There's the things we have to do, but there's so much more that this can do. And that's what I mean about, it's not just about ambition around the date, it is about ambition around the task as well. So thank you.
Thank you very much. I think we'll probably draw a conclusion to this discussion. Jane, you did ask about the date.
Yes.
Whether it'd be ambitious enough. I suppose unless someone's got a particular proposal, I think what I'd suggest is that as you develop this, you come back to us when you've got more, concrete realism, if I can put it that way, of what's possible, and indeed, what's the consequences of doing it. That maybe come back. So I think we should be ambitious. I think from this discussion, I think we can see that the board is very committed to this agenda. I think the things that we do, I hope, will be sort of real, that is substantive, make a difference, because there's a danger with some of these things that have a sort of emotional side to them, that we can do lots of things that feel good but don't actually make much difference. And I think we've got to concentrate on those things to really make a difference. But I think there's no shortage of support for this agenda. So thanks for your report. We look forward to hearing the progress, and I'm sure Naomi will be pleased to tell you all the answers.
Thank you. Appreciate your time. Thank you very much.
That's great. No, thank you, Jane. Very good. Okay, well, that's an important topic, a good subject to discuss. Shall we move on then to 9.2 strategy implementation plan? Alex, I think this is just an update for us.
Thanks, Martin. And I took the feedback from the last board that the information was too detailed. This paper is aiming to provide an overview of the current status of our strategic initiatives. I think we may have swung a bit too far away from giving a crisp view of kind of the must-do high-impact strategic initiatives in this report, and I'll continue to adjust that. But I'm hoping it gives the board a view of current exceptions and an overview of the state of play on our strategic initiatives.
Could I just ask if someone could just give us a little update on the bed optimisation? Excuse me.
Well, as we have the benefit of Jane on the board today, I'll ask Jane Reynolds to update as the lead for that project. Thanks,
Okay,
Jane.
Thanks, Alex. We did pause our bed optimisation in terms of the 4 work streams through January because of COVID, but we did keep in weekly status exchanges, and we've brought in a piece of work now on medically fit for discharge. And instead of just looking at length of stay or medically fit for discharge, we've got a pathway now to look at anticipatory care in mental health. And so we're relaunching all of that next week. We've done all of the data behind that, and the teams are all ready to mobilise. We've also re-enacting the PQ length of stay piece of work, and that's already got an A3, and we've got the tasks for that, so taking that forward. And we're looking at out of hospital alternatives to admission around the rehab pathway, step up and step down. And there's a paper going to Trust Business Group in February on that. The numbers of out of area placements have come down. We're running at about 24 at the moment, and only 3 of those are currently inappropriate because we've contracted extra beds. Done a piece of work to look how we exit those extra beds come April, and we will do it on a sliding scale because we won't be able to get rid of all of them all at once. But we've determined that we won't use the PQ beds post-April, extra contractual PQ beds, because they've not been a good use of resource. They've not been full. We've purchased 5 and it's been really difficult to access them, so we won't be doing that going forward. But the 14 beds we've used in the acute sector have been used very, very well and utilised well, and so we'll look to reduce that amount. We've re-looked at the out of area placements in terms of the NHSI ask, and we've put in a new trajectory for that takes us to getting to 0 by 2023, end of Q4 of this next financial year. We're still reporting a good position, although we might not feel so in the organisation, but we're not an outlier in terms of our out of area placements. We're actually tracking very well. Our biggest issue going forward, and I've spoken to Paul about this, is once the money dries up for those additional beds in terms of COVID, we have got a cost pressure come April. David is doing a piece of work on procuring somebody to come in and to look at our bed base and see whether we've got enough beds for the next 3 to 5 years. And so that'll sit alongside this piece of work as well. So we've got project management support on all of this, and we will relaunch next week, and we'll be able to do monthly reports then into a programme board, because that programme board steps back up next week. We've got leads on all of the work and everything's ready to go.
Okay, thank you very much, Jane. Very clear. Any other questions for Alex? And Alex, I think that it's an evolving issue about the format of the report. I think it's just important the board has, clarity rather than 50 pages. But I think it's useful just to have the highlights. I mean, I found it very easy to pick up the highlights. Anyway, we look forward to that. Anything else you want to say, Alex, on this?
That's all. Thanks, Martin.
Okay, shall we then move on? Where are we? Councillor Governors update. Just to say that the last Councillor Governors, which was a joint one with NEDs and Governors, I think went very well. The Governors were very pleased. They're very positive view. I think they found the time with the NEDs, these small groups, breakout groups we have, very productive. And there's some good discussions, and I was very pleased to see it. Quite a lively meeting, I think. So I just felt that was, we're getting there in terms of the way we run these, I think, and the style of online meetings is going quite well. I've got nothing else to say unless anyone wants to raise anything. But,
two good presentations too as well, I thought, health and wellbeing and the the patient experience as well, which I think people were really interested in as well. So
They were.
That set it up quite nicely. They were just high quality presentations, actually, both of them, and I think they landed well with the governors as well, because I think they were of natural interest to them. You know, what's happening for our staff well-being, and you know, how are we finding out what patients really need? And I think they enjoyed that actually, and they were both well presented as well, I thought.
Yeah, I agree absolutely. Thank you for that. Okay. Annual health and safety report, item 10.1. David.
Thanks, Martin. I think hopefully the report is self-explanatory. I think it's been a difficult year, and that's sort of shown within the health and safety report. We haven't had any enforcement notices, but we have had an increase in the number of fires, and we have had an increase, as we know, because we're tracking it on physical assault staff. And we've seen improvements in our training regime, and we've had challenges around sickness as well, which we're aware of as a result of COVID. That said, I think compared nationally, we haven't done too bad, and we've seen some improvements in some area. We're working well with the Royal Berkshire Fire and Rescue Service and doing some joint development work with them, which is progressing well. But otherwise, I would just open it up to questions on any particular aspects of the report.
Yeah, the things that I just highlighted just when I was reading it through, one was the assaults on staff, which you just alluded to, and which I know we're addressing with vigour, and the other was just the sickness figures, just so that we can understand the COVID versus non-COVID, which is at the bottom of page 279. Otherwise, I've got nothing else. Anyone got any comments or questions?
Yes, Martin, just to say we're working with Frimley as well on violence and aggression, because traditionally, well, factually, mental health and learning disability trusts have experienced the most violence to their staff, but aggression has also increased as well quite markedly, particularly after the first wave of lockdown. So acute trusts, you know, getting all sorts of challenges around people having to wear PPE, you know, face masks, face coverings, all that type of thing, really. So we are, as well as doing our bespoke piece of work, which you'll know about prospects and everything else, we are working with Frimley as well on a sort of campaign, if you like, a more local campaign, which is about obviously not necessarily the hands-on violence, but certainly the aggression that sometimes can lead to that, but also can have a huge impact, a negative impact. So we think about turnover and retaining people. There's nothing that sucks the joy out of work like being abused for asking people to do the right thing and things like that. So again, it's another area where Jane and her colleagues, HRD colleagues, Director of People colleagues, are working on something collectively to try and do something based on good practice evidence and trying to shift the agenda locally, which I think will be really helpful, because we are seeing an unfortunate and unacceptable rise in aggression towards NHS staff.
Thank you very much. Any other comments? Okay, Audit Committee minutes. Rajiv, do you have anything to say, or just happy to take questions? Or
no, thank you, Martin. So I think the paper's on page 291. I would just say it was a standard agenda for January. The two things that we did slightly out of the norm were we had a fraud awareness seminar just before the Audit Committee meeting, which actually I found very informative to talk about the challenges that fraud brings in the NHS in particular. And then we had a presentation of the quality improvement program in the context of value for money, and I think we concluded that given the investment that we've made in the program to date, there should be an annual review, but it would more appropriately go to the quality and performance executive group. So those are the things I'd call out.
Thank you very much. Any other questions, comments? No. Okay. Thank you very much, Rajiv. Declarations of interest for fit and proper persons. Julie.
Yeah, this is just our annual assurance paper for the board to know that we've continued to do our fit and proper person tests, and an opportunity for people to review the board's declarations of interest.
Okay, so if there's any changes, let Julie know. Annual trust board meeting planner, Julie.
Again, this is just for information. Annually, we take this to the board. I mean, it's not set in stone. There will be additional papers throughout the year. It just gives the board an idea of the forthcoming business for the year.
I can't remember. Did we did we do this bit of putting the individual topics and the frequency they come up at the board, just for clarification?
Yes, it's the second page of the report.
Okay. Okay, that's fine. Thanks very much. Trust Seal report, Paul.
Yeah, thanks, Martin. Just to know, I think we previously reported that the buyer for the original buyer for 3 to 5 Craven Road had fallen through. So this was just confirmation we'd used the seal, and we've completed on the purchase with the second bidder on the list.
Okay. Thank you very much. So, any other business? Anyone got anything they want to raise? Okay, next public meeting is the 12th of April 22, and we'll now adopt our resolution to exclude the press and public from the remainder of the meeting as normal. What time are we now? Shall we say